Подожди, вот Lala зашла, кажется.
Salam, hər vaxtınız xeyir.
Salam aleyküm, necəsiniz?
Akşamınız xeyir, axşamınız
Akşamınız
xeyir.
xeyir.
Uğurlu konferanslar, webinarlar sizə.
Sağ olun.
Çok sağ ol. Hamımıza. А у меня голос почему такой низкий?
Нормально.
Нормально слышно?
Hər şey gözəl.
Я вас плохо слышу почему-то.
O deyəm.
Тут написано try multi-speaker view. Что такое новое-то? Голос. Откуда поднять голос? Audio setting.
Kompüter necə səs verirsə, elə səs verin, artacaq səs.
Verirəm, axı, у меня максимальный голос сейчас стоит. А может быть... Aha.
Nauşnikdə istifadə etsəz yaxşı olar. Belə olanda görürsən, səs yayılır eləyir 2-3 nəfər danışanda. Nauşnik versə, fikirlər nauşnik keçsin.
Наушник. Siz məndə bu переходник.
Mən nauşnikdəyim. Telefonun nauşnik varsa onu da qoşa bilərsən.
Хорошо слышишь
Lalə xan,
меня?
webinar zamanı bağlayacaqsınız videoları, yoxsa gedəcək?
Может быть, мы, может, в WhatsApp
Eşitmədin, nə?
поэтому. Сейчас я WhatsApp отключу тогда, Имра.
Webinar vaxtı videoları bağlayacaqsınız, yoxsa hamının videosu göstərəcək?
İndi eşidirəm.
Görsənməsin, Emin doktor. Səslər
Mən paralel WhatsApp-daydım, ona görə.
Ürəkdə alır bəzən, ona görə deyirəm. Sizin yenə də biləcəyiniz məsləhət, necə istəyirsiniz?
Emin doktor.
Hə,
Mən eşidilirəm indi normal.
super, hər şey gözəl.
Ha, qəşəng. Qəşəng. Biz danışanda avtomatik şəkillərimiz çıxacaq belə, yoxsa necə?
Bəli, siz danışan kimi görünürsünüz, speaker kimi.
Ha, siz danışan kimi siz gəldiniz.
Hı hı.
Rena Gayva, Lana Datuşvili.
Lana это. Hello, Lana. Georgia. How are you? Lana?
Good evening.
Hello.
Hello, how are you?
Fine. How are you?
Nice to see you. Fine, thanks. Welcome.
You.
Hi to everybody.
Hi. Hello.
Hello.
Hi.
You are in OT, I think. Yeah? Ameliyat otağındaydın.
Yeah, are you still at work?
Yeah.
Yeah, operating theater, or is this your...
No, I had the procedure, just
Yeah.
something about aesthetics.
Oh, yeah. You love the one.
Yeah.
Emir ile bir şeyde Elmler Akademiyası'nda oturup ne kadar kitaplar.
Mənim kabinetimdir.
Maşallah. Bir de o aramızda okuyan bir ders sen diyorsun.
Allah Allah.
Ha, mən başqa tərəf.
To visiting, but today we're virtual though, so we'll stick to virtual for now.
Yeah. Hopefully one day it'll be in person.
Well, great. Well, listen, thank you for having me here. I've there's lots of different things to talk about in glaucoma and anterior segment, but I prepared some slides on MIGS. I was going to ask actually before, what is the state of MIGS in Azerbaijan? Are people doing MIGS or not? Some people are muted.
Yeah, Dr. Jamil, would you like to answer, Dr. Jamil Imran? Hello.
Hello, Dr. Ahmed. Thank you
Hello.
for your find in your busy schedule time to be presenter in this webinar. Yes, we actually start the canaloplasty surgery, phaco canaloplasty surgery from 2011 in Azerbaijan, but it was ab externe surgery. And we use the ProLens stent, and we make this surgery for early, moderate, and advanced stage pseudoexudative glaucoma. We have long-term study. And regarding the MIGS procedure, now in 2024, from early this year, we start to do the Omni
Yeah.
and the eye track advance. We use the canaloplasty by ABIC and with Omni devices. So
Good. Okay. So you have some broad experience, which is great. Excellent.
and
So-
regarding the stents, eye stent, I think the Dr. Imran want to say
No.
something.
Not interesting for me about the certification.
Yeah, we also have a little bit of experience with the MIGS. Can you hear me?
Yeah.
Yeah, Lale, can you hear me?
Yeah.
So we also have some
Dr. Oek,
experience
is that
with
okay? Can you hear them?
Çok
Ya.
dinler. Silotka dinler.
Çox xahiş eləyirəm, mute qoşun da. Mən hamını mute eləyə bilmirəm.
Mute nereden
So-
yaman?
So, Dr. Ahmed, we have some experience with the iStent, the first generation, and then some with Hydrus and with Kahoot Blade.
Great. Well, yeah, I mean, I think it's fantastic. So many of you have had a broad experience, which is helpful. And I think it'll be really good to have some discussion. So I know we're going to be here for probably an hour, I think. Is that the plan?
Yeah.
So I will try not to go too long on my presentation. Maybe I will, skip a couple of slides just because some of you have experience, some of you don't. And maybe have a good discussion about this because, MIGS continues to evolve and we can talk a lot of different aspects of it. So let's jump in. I love to see people's faces. I always see people's names. So if you want to turn your camera on, I always find it's nice to do that, unless you're maybe like, in a compromised situation, maybe then don't turn your camera on. I'll leave it up to you.
Değerli hemkarlar, kameralarınızı açsanız.
Yes, that's great. Okay, 2 people listen to us. The rest of you are losers. I'm just kidding. There you go. I'd like to see you guys. Okay, so listen, let's get into it. These are my disclosures. So what I was hoping today, because I realized probably this group is pretty diverse. There's some people who have a lot of experience in MIGS, some people who are just still early and learning, and some people who've never really heard about MIGS and done them. Although I think nowadays this is something that's being talked about more and more. And we're pretty excited about all the different studies that have been done now with MIGS. But I'll talk a bit about the rationale, talk about patient selection, surgical tips, maybe talk about complications if we have time. These are all things that we can discuss. I want to first state that, listen, glaucoma is still a really serious disease, even in North America. I mean, patients still go blind. People still are poorly compliant. Quality of life with the medications is not great. So although we talk about blindness and glaucoma, there's a reality is that many of our patients are struggling with the medications, are struggling with good control. And that's why if you look now, many of us are talking about interventional glaucoma, which is not just MIGS. Interventional glaucoma to me means, having a mindset to be proactive and treat glaucoma earlier by intervention. Laser trabeculoplasty, SLT laser has become first line for many of us. Drug delivery, which is only becoming available now, is being used earlier. We can inject medicine in the eye. And then MIGS, whether it's combined with cataract, which of course is the most commonplace, or whether it's done standalone, are emerging as earlier interventions. And then even with bleb surgery, we're doing more in terms of novel ways to do bleb surgery. So at least in surgery today, we have a variety of options, whether they're Schemm's canal or whether they are bleb based, subconjunctival. And in the bleb field, we have, we still do trabs. We have what we call micro-invasive bleb surgery. We won't talk about this much. And we have tube surgery and trab surgery. So there are a variety of options. And obviously, the way we decide on surgeries is balancing out safety and efficacy. I think we would say MIGS has better safety, but not as much efficacy. And bleb surgery has more efficacy, but not as much safety. So it's really about selecting the right patient. And this is kind of our original paper about how we define MIGS. And the biggest point with MIGS is that this is really meant to be a safer option we can use earlier, a faster recovery. And, the goal of MIGS is to address particularly some of the shortcomings of medications. One of the problems with MIGS is that people often compare it to trabeculectomy. I think this is a mistake because MIGS is not designed to replace trabeculectomy. It's designed to replace medications, for example, like trabeculoplasty or SLT. It's designed to be adjunctive to medications when the disease is not so severe. So this is, for me, what I'd like to kind of differentiate with MIGS. And so MIGS has, a certain role to play in this interventional glaucoma era. I would say anybody in glaucoma nowadays are thinking about, should I take the patient to the operating room sooner than they usually do? And it's because we have so many options available now in the whole new procedure. And, here we just talk about some of the MIGS procedures, Schlemm's canal and supraciliary space. Suprachoroidal space is an interesting area. We have some new products coming in this area. We, of course, have old techniques like cyclodialysis cleft, but these have not become popular because of the lack of predictability. We'll see what happens with the newer devices. We're still doing some clinical trials. We have some experiences in these, but I'll speak primarily on Schlemm's canal procedures. And then we have MIBS procedures as well, and BLEP procedures. So when it comes to Schlemm's canal procedures, what I would say is that these are basically ways that we can manage patients with different approaches for MIGS, where basically we can essentially use cutting approaches, ablation approaches, or dilation approaches. So when we talk about MIGS, it's helpful to differentiate procedures that cut, procedures that ablate, and procedures that dilate. And you can see on the right, we have all the options that are available to us that one can use in this era. And I'll be honest with you, it's very confusing nowadays because we have so many options available to us now that we can use, and it creates some confusion. We just heard earlier, eye track, eye stent, Omni, suture GAT. Where do we choose one or the other? And quite frankly, there is a lot of debate which approach is the best one, which approach is going to be the most cost effective. Some of these products cost $1,500, $1,000. Other approaches cost maybe $5. So what is the best approach? I think for me, I answer it and say, listen, MIGS can be done anywhere around the world. We don't need to have a large budget to do MIGS, but there are certain things that are more expensive, and maybe there are some improvements in terms of the predictability and safety, possibly. We already heard about iStent. iStent has been around for many years with different generations of iStents. These are the smallest implants in the human body. And, these procedures have really made MIGS procedures very finessed. So here, what I'm showing here, example, actually, first of all, I'm showing a special lens here. This is called the DVX lens. And this lens, we do not need to tilt the microscope. So I'll talk about that shortly, because in most MIGS procedures, we're using a prism. But in this case, we're using a double mirror, so no tilt in the microscope. But what I want to show primarily here is we have 3 stents in this particular procedure, and we can deliver these with really precision placed intratrabecular meshwork, as you can see, very precisely located in position. There's one. There's a second one placed here, and a third one placed here. So usually we place them nasally. We sit temporally, and you can see we have very good placement there to show that. I hope the video is playing okay. I know that on Zoom sometimes it's a little bit staggered
It's
and stuttered.
blurry.
Yeah, we can see it. We can see it.
Yeah. But with video, sometimes it is blurry. So those 3 stents in there are nicely placed. We also have the Hydrus device, which is a longer stent, which covers, in this case, 3 clock hours, and allows us to cover a lot of area. Here we're showing the stent placed, and you can see we're using a gonio prism here. The device is in a cannula, and we're using the cannula to enter the trabecular meshwork. And this is all done under topical anesthesia, very clean surgery, corneal incisions, and really a very proficient surgery that can be very easily combined with phaco.